Imagine wrapping your hands around a freshly poured cup of coffee. You can feel the smooth ceramic, the weight of the liquid, and the shape of the handle. But you have no idea that the scalding water is currently giving you third-degree burns. In neurology, this is known as dissociated sensory loss. It's a condition where the perception of pain and temperature vanishes, yet the sense of touch, pressure, and vibration remains perfectly intact. Without the alarm bell of pain, severe injuries go unnoticed. Patients often arrive at clinics with deep burns from stoves they didn't know they touched, or with Charcot joints, severe joint destruction caused by accumulated, unfelt microtraumas in the hands and arms. This sensory separation shows that tactile experiences, everything from the heat of a flame to the texture of a mug, travel along distinct, independent physical circuits within the body. This selective numbness rarely affects the whole body. Instead, it targets a very specific region, almost always beginning in the upper extremities. As shown in this clinical map, pain and temperature loss follows a distinct cape-like distribution, draping across the shoulders, chest, and arms. This pattern is the hallmark of syringomyelia, caused by a fluid-filled cavity forming deep within the spinal cord, far beneath the skin. By expanding outward from the center of the spine, the disease severs specific sensory connections while leaving the adjacent pathways functional. Syringomyelia begins when the flow of cerebrospinal fluid is obstructed. This clear liquid normally circulates around the brain and spine to provide a vital cushion. Several physical culprits can block this flow, including internal scarring from past trauma or meningitis, or congenital structural defects like Chiari malformations at the base of the skull. When normal pathways are blocked, trapped fluid is forced inward. It pools, expanding the spinal cord's central canal into a fluid-filled cavity called a syrinx. This creates immense internal pressure, acting like a slow-motion water balloon inflating inside the delicate nerve tissues. The core danger lies in the specific anatomical real estate the cyst crushes as it expands outward from the absolute center of the cord. To solve the mystery of why touch is spared while pain is lost, we have to look at the microscopic geography of these nerve fibers. The signals for fine touch and vibration travel up the very back edge of the spinal cord in bundles called the posterior columns. They are tucked safely away from the center. The fibers carrying pain and temperature take a different route. They cross directly through the exact center of the spinal cord to reach the opposite side before traveling to the brain. As the syrinx inflates, it acts as an internal wedge. It physically snaps those crossing pain fibers while failing to reach the touch fibers located at the rear of the cord. This inside-out structural demolition is the only way a person can selectively lose the ability to feel a flame without losing the feeling of a feather. The syrinx rarely stops growing after the sensory fibers are destroyed. Eventually, it continues its outward march into the territories responsible for movement. This expansion causes flaccid weakness, a loss of deep tendon reflexes, and severe muscle wasting. If the cyst pushes into the sympathetic nervous pathways, it can trigger Horner syndrome. This is a condition where a patient develops a drooping eyelid and a constricted pupil on just one side of the face. A catastrophic scenario occurs if the cyst extends upward into the brainstem. This progression is known as syringomyelia. In these diagrams, you can see the manifestations of brainstem involvement. Patients develop swallowing difficulties and nystagmus, an uncontrollable rhythmic oscillation of the eyes that can move horizontally, vertically, or in a circle. What begins as a sensory quirk relentlessly progresses into a systematic dismantling of motor control and vital functions. Before the 1980s, confirming this condition was nearly impossible. It was a ghost disease, diagnosed entirely by deducing the location of the damage based on a patient's symptoms. The MRI scanner changed the diagnostic landscape. It uses magnetic fields and radio waves to reveal the spine's soft tissues in high definition. An MRI provides undeniable visual confirmation, showing the exact size and location of the fluid-filled cavity lurking inside the spinal cord. Modern imaging replaced clinical deduction with visual evidence, allowing doctors to identify syringomyelia as a precise, verifiable structural defect. Because this is a mechanical pressure problem, there is no pill to dissolve the cyst. Surgeons must address the underlying plumbing issue. Treatment involves either restoring the normal flow of fluid at the base of the skull or physically draining the cavity. If the syrinx is dangerously large, neurosurgeons place a syrinx subarachnoid shunt. This is a small artificial tube that acts as a pressure release valve. This shunt allows the trapped fluid to drain safely, stopping the expansion and preventing further nerve destruction. Human neuroanatomy is an incredibly dense highway where a fluid disruption of just a few millimeters alters how we perceive and interact with reality.